Hello, my name is Danielle Hitch, and I'm an Associate Professor of Occupational Therapy at Deakin University and Western Health in Victoria, Australia. Thank you for viewing this presentation, which I hope will be helpful to your work with war survivors. I'd like to begin by acknowledging the traditional custodians of the unceded lands, skies and waterways on which this work was produced. I pay my deep respects to the ancestors and elders of Wurundjeri and Wathaurong country in recognition of the deep history and culture of these lands. I also want to honour and acknowledge the spirit and resilience of all war survivors. I recognise both the civilians, whose daily lives are shattered by conflict they did not choose, and the combatants, who face unimaginable hardships on the battlefield. I acknowledge the strength it takes to rebuild lives and communities torn apart by conflict. To every survivor and to every occupational therapist who works with them, I offer my respect and solidarity. I would also like to acknowledge that some of you watching this webinar will have your own experiences of trauma. The content of this session will touch on many sensitive and upsetting topics. Some of this content might resonate with your own experiences and cause you to feel uncomfortable, upset, or emotional. Please prioritise your well-being throughout this session. If at any point you find the material to be overwhelming or distressing, I encourage you to take the steps you need to manage your comfort. This might include stopping the video, taking a break, or speaking with a support person. Remember, the purpose of this webinar is not only to learn how to support others, but also to acknowledge your own need to take care of yourself. Your health and well-being matter just as much as your patients and should be prioritised. We cannot care for others if we cannot care for ourselves. Thank you for being here and for engaging with this important subject matter with care and respect. After viewing this webinar, you will be able to do the following. You will understand the key concepts and terms related to trauma-informed care. You will also be familiar with the principles of trauma-informed care. And you'll be able to identify a range of ways in which occupational therapists can support people experiencing trauma. Trauma refers to an event or series of events that overwhelms an individual's ability to cope and negatively impacts their mental, emotional, and physical well-being. Traumatic events can have a profound and long-lasting impact on a person's life. It affects all areas of occupational engagement and participation. Every activity that a person wants to do, has to do, and needs to do could be impacted by the effects of trauma. People exposed to conflict or war, either as civilians or combatants, experience a range of and often multiple traumatic events. These may include witnessing or being subjected to violence, the threat of injury or death, seeing the injury or death of others, including family and friends, displacement from their homes, and a loss of community and way of life. There are some key terms used when speaking about trauma I would like to make you familiar with. Psychological or emotional safety involves ensuring that environments are welcoming and make people feel secure, empowered, and free to speak without fear of being humiliated, marginalised, or punished. This concept recognises that safety is more than just physical security or protection from physical harm. Many of the forms of trauma we will soon discuss occur within and are significantly affected by psychologically or emotionally unsafe environments. You may well have heard of the term fight or flight. This refers to a neurological reflex that is triggered by the perception of serious threat. The two Fs have now also been joined by freezing, which is also a common response to threat. These are primary survival responses which can become overactive in a person who has experienced trauma. Speaking of triggers, these may be anything that resembles, symbolises, or is connected to a traumatic event. Triggers can take many forms, including sensory experiences like smells or sounds, objects, anniversaries, phrases, or reports of related events. A trigger automatically provokes a memory of the person's own traumatic event, followed by a survival response. This is not a conscious process, and the person has no control over this. For example, the sound of a screeching tyre and a minor collision may trigger a strong emotional response for someone who was previously in a traffic accident, even if no one was hurt. And finally, the concept of violence is used frequently during discussions of trauma. Violence is defined as the potential or actual experience of physical power, which is directed at the individual or someone associated with them. Violent acts are highly likely to cause physical, mental, emotional, sexual, or verbal harm. Let's cover some of the types of trauma that are particularly relevant to conflict and war. The following information has been drawn from the Los Angeles Public Health Department and the National Child Trauma Stress Network, which are both located in the United States. Adverse childhood experiences, or ACEs, are traumatic events occurring during childhood, which include abuse, neglect, losing a parent, and living with family members experiencing substance abuse. According to Save the Children, approximately 468 million children, or more than 1 in 6, are living in a conflict zone globally in 2022. This was a 2.8% increase from the previous year, and the number may now therefore be even higher. Carceral trauma occurs because of imprisonment, detention, or the forced separation and isolation from loved ones in the community. Both combatants and civilians may be subject to these conditions during conflict or war. Childhood or developmental trauma is an umbrella term for trauma experienced by people under 18 years of age, which can have an effect on many of their developmental stages. This could include events that have occurred to them, like physical abuse, witnessing family violence, natural disaster, or conflict or war. It can also include a lack of resources brought about by neglect, or disrupted attachment due to the trauma of a family member, often a parent. Chronic trauma refers to persistent, recurring, and prolonged trauma across multiple events. Collective trauma occurs when communities break down due to a shared experience of trauma, which can cause a loss of identity, cohesion, roles, boundaries, and identity. Physical trauma may occur following painful and sudden injury to the body, which both combatants and civilians may experience during conflict or war. Conversely, psychological or emotional trauma can result from harm done to a person's identity or emotional self, which makes the person feel diminished or threatened. The following forms of trauma may also have been experienced by your patients and are undoubtedly related to experiences of conflict and war. Acute trauma refers to a one-off event or experience and is also known as single incident trauma. For example, being a victim of crime or having an accident. Some people have an immediate trauma response. Others may have a limited or even no response. And for others, their trauma may re-emerge later in life. Bullying occurs when someone deliberately inflicts social, emotional, physical, or psychological harm on another that they perceive to be weaker or less valuable than themselves. We often think of bullying as something that only occurs in childhood, but adults may also experience bullying in their families, social networks, or workplaces. Family violence, also known as domestic violence, refers to threatening, coercive, dominating, or abusive behaviour between people within a family or domestic context, which causes fear to the victim. These relationships may be current or historic as when a person experienced abuse from a former partner. Intimate partner violence, or IPV, involves violence or abuse that occurs within a relationship where one partner maintains power or control over another. This may include physical violence, sexual assault and abuse, stalking, date violence, or coercive control, where a person takes away another person's freedom or unreasonably controls their day-to-day life. Historical trauma occurs when marginalisation, stigma, discrimination, or oppression inflicts significant and ongoing psychological wounds for specific ethnic or cultural groups. This form of trauma is passed down between generations via its impact on survivors as parents and ongoing marginalisation of the group. Examples of sources for historical trauma include the Jewish Holocaust of the Second World War and the Rwandan genocide of the 1990s. While immigration is a positive experience for many people, immigration trauma may occur when people are forcibly displaced or become an asylum seeker or refugee. Medical trauma can occur for people who have been subject to single or multiple medical events and their treatment. For example, a person who has undergone prolonged cancer treatment or painful dental treatment may find returning to a medical facility extremely stressful. This form of trauma may be related to their injury or illness, their treatment, or both. Natural disaster trauma can follow events such as cyclones or hurricanes, earthquakes, tsunamis, bushfires, drought, heat waves, and flood. A region where conflict or war is occurring may also be hit by natural disasters, further compounding the trauma experienced by the people living there. Racial trauma can occur for people who experience sustained violence and abuse as a result of interpersonal and systemic racism, prejudice and bias. Racism may occur during face-to-face encounters with others, via government policies, or online, including social media. Sex trafficking involves the coerced exchange of sexual acts for something of value, such as money, shelter, food, clothing, drugs. While some people freely choose to undertake sex work, others are forced to and may experience trauma from the work itself or associated trauma. And finally, vicarious trauma, also known as secondary trauma, refers to the profound emotional and psychological impact of engaging with the traumatic experiences of others. This form of trauma is particularly prevalent in health professionals, who engage with patients experiencing trauma over the course of their careers. Vicarious trauma may accumulate gradually over time to the point where it has a similar impact on health and well-being as direct trauma. Trauma is a complex phenomenon with multiple manifestations. A large number of specific types of trauma have been identified, and the people you are working with may have experienced one or more of them. The impacts of these various types of trauma may also differ in terms of the symptoms or consequences experienced and their severity. Take Ibrahim, for example. Ibrahim is a 25-year-old Palestinian man who lives with his wife and young son. In his teenage years, Ibrahim developed leukemia, but achieved remission after 2 gruelling years of treatment. While he was born in Gaza, his family emigrated to Australia when he was 8 years old. Most of his wider family remain in Palestine and have been displaced to refugee camps in recent months. Ibrahim has potentially experienced direct trauma from conflict in Gaza during his early childhood, his leukemia diagnosis, marginalisation or racism in Australia, or other life events that we don't know about. He may also be experiencing vicarious or second-hand trauma from what his broader family are going through. Or he may not see any of these events as traumatic. Remember the definition of trauma I gave you at the start. An event or series of events that overwhelms a person's ability to cope and negatively impacts their mental, emotional, and physical well-being. Ibrahim may have developed a range of effective coping skills and may have access to a strong and supportive social network. His beliefs, both religious and personal, may have assisted him in making sense of the events that have happened to him in a way that he feels he can manage. It's important to understand how your patient is making sense of their experiences and not just assume that they are traumatised. It's just as important not to underestimate how traumatising an event may be for someone. While it may seem like a small thing to you, they may not have had the coping skills and well-being supports that you have. Trauma is therefore an intensely personal experience, and its severity can't be objectively scored or rated. The impact of trauma is determined by the interaction of many factors, which interact with each other in extremely complex ways, much like occupation itself. It all depends on a person's lived or living experience. That is, the personal understanding an individual builds from their involvement in traumatic events, rather than your interpretation of their experience. In regards to prevalence, 3.6% of the world's population experience post-traumatic stress disorder every year. 8% of women and 4% of men develop post-traumatic stress disorder at some point in their lives. Combatants in conflict and civilians are more likely to develop post-traumatic stress disorder than any other group. It's important to note that over 90% of people do not develop ongoing symptoms of trauma, even when exposed to traumatic events. Strong social supports, coping strategies like optimism, resilience and adaptation, and higher cognitive abilities have been shown to protect people from longer-term mental health issues related to trauma. You can't assume that everyone who has experienced conflict or war will have problems related to trauma. Humans are remarkably resilient, but you should also be aware that it is likely the person has experienced a trauma and sensitive to their individual experience of it and the consequences this may have for their life and occupations. Responses to traumatic events can in themselves have a negative impact on a person's health, well-being and opportunities. Every person's symptom profile is unique and it may fluctuate over time. From an emotional and psychological point of view, trauma is associated with a wide range of symptoms, as shown here. It is also associated with changes to a person's perception of themselves or the world, intrusive thoughts about the traumatic event, risky and self-destructive behaviours, and difficulties with trust and attachment. So trauma also has an impact on the neurological, biological, and social systems and supports of people. The symptoms displayed here are easily attributed to diseases and psychological issues which may also be occurring for the person at the same time. For example, symptoms like anxiety, depression, sleep disturbances, and mood swings can be associated with both traumatic stress and other mental health disorders like depression or bipolar disorder. Physical symptoms like fatigue and chronic pain might be attributed to physical illnesses or chronic conditions without recognising their potential traumatic origins. There is often a stigma associated with trauma-related conditions like post-traumatic stress disorder or PTSD, which may lead individuals to underreport or minimise their trauma history when seeking help. This can lead on to a focus of treating the symptoms rather than addressing the underlying trauma. Diagnostic overshadowing can also occur when clinicians assume all symptoms are due to a primary diagnosis and don't consider trauma as a contributing factor. People with trauma can present in complex ways because it can impact on so many areas of their life, and is also influenced by dynamic factors like age, social circumstances, and the presence of supportive relationships. This can make it really difficult to clearly identify trauma as a cause of current health issues, especially when symptoms emerge long after the traumatic event occurred. It's not the role of occupational therapists to diagnose trauma, but keeping a trauma-informed perspective enables us to work with our colleagues from other disciplines, such as medicine, psychology, and social work, to collectively understand whether trauma may be a factor in the patient's occupational participation. The most common trauma-related diagnosis in regards to mental health is post-traumatic stress disorder, or PTSD. This slide provides the diagnostic criteria for PTSD according to the DSM-5, just to provide you with an idea of what it may look like in your practice. According to the National Health Service from the United Kingdom, about 1 in 3 people who experience severe trauma go on to develop the symptoms of PTSD. Therefore, again, the majority of people do not develop this condition. However, there are some factors that seem to put people at a higher risk of developing PTSD. These include having previous exposure to traumatic experiences, especially during childhood, getting hurt or witnessing others being hurt or killed, experiencing horror, helplessness, or extreme fear, a lack of social support after the traumatic event, experiencing further stresses in life, and a personal or family history of mental illness. While these risk factors are not causes of PTSD in and of themselves, they are useful to know should your patient undergo a traumatic experience. If a patient has any of these risk factors, their treating team should be proactive in ensuring they have the support they need in the aftermath of a traumatic event to potentially prevent the development of PTSD. Trauma-informed practice is a strength-based approach and therefore aligns closely with the philosophy and values of occupational therapy. Occupational therapists who adopt the principles of trauma-informed practice have to shift their perspective from being a caretaker to being in partnership with the patient. As such, trauma-informed practice is a client-centered practice. Your goal is to enable the patient rather than treat them. Trauma-informed practice is intended to be implemented as a universal precaution. This means its principles are embedded in all aspects of practice, rather than being applied to specific patients. The goal is to prevent or address trauma and re-traumatization for every patient. This removes the requirement for patients to disclose their trauma. Similar to recovery-oriented practice, the principles of trauma-informed practice are intended to support optimal health and well-being for everyone, regardless of their lived or living experience of trauma up to that point in their lives. It is an intervention that operates at the service level, rather than at the level of individual occupational therapists. Every part of your service or program should be founded on knowledge about the impact of trauma on your patients. Watching this webinar goes some way to providing you with this foundation knowledge, but there are always new things to learn, and I would encourage you to seek out further training and education specific to your local context and culture. When implemented at a service-wide level, trauma-informed practice can enable patients to develop a greater sense of control in life and rebuild their connectedness and belonging to communities. It should also be acknowledged that health and welfare services, in and of themselves, can cause trauma. And this approach also involves developing awareness of how your service could inadvertently harm your patients. These issues should be identified from a combination of reflection by clinicians and feedback from your patients. Once identified, they can be addressed to remove the risk of traumatization or re-traumatization for people attending your service. It's very important to understand that trauma-informed practice is not the same as trauma-specific or trauma-focused care. These approaches use specific interventions to treat the symptoms and consequences of trauma. For example, eye movement desensitization and reprocessing, or EMDR, or prolonged exposure therapy, also known as PE. Only occupational therapists with advanced training and close supervision can deliver these interventions, and they should never be attempted by therapists without this expertise due to the high risk of re-traumatization if applied incorrectly. There is no single trauma-informed practice framework. However, most that are available internationally refer to the principles listed below. Number 1. Understanding trauma and its impact. You must have an understanding of trauma, including its prevalence and impacts, to provide trauma-informed practice. This includes an understanding of the complex ways in which trauma can present and have an impact on health and well-being. Number 2. Promoting safety. Your service should ensure every patient's basic needs are met in an environment which supports physical and emotional safety. This includes having policies and procedures to respond to risks to self, including thoughts or acts of self-harm. A safe service provides responses that are consistent, predictable, and respectful. Number 3. Ensuring cultural competence. Trauma is deeply embedded within cultural contexts, which influence lived experiences and responses to traumatic events. Your service must demonstrate to patients that it respects diversity by providing culturally sensitive interventions and opportunities for people to engage in cultural rituals and activities. Number 4. Supporting consumer control, choice and autonomy. A key aspect of recovery from trauma is regaining a sense of control over daily life. As a partner, rather than a caregiver, your role is to strengthen the patient's sense of autonomy by keeping them updated with any changes to the service, being clear about expectations, and understanding the patient's expectations of you, engaging in shared decision-making, collaboratively setting goals, and upholding basic human rights and freedoms. The Universal Declaration of Human Rights from the United Nations lays out the fundamental human rights that everyone should have. Number 5. Sharing power and governance. This principle speaks to the need to decrease power differences. This involves sharing decision-making power and involving patients in the planning and delivery of your service at all levels of the organisation. Steps you can take towards this principle include involving patients in the creation of policies and procedures and working towards co-facilitation of therapeutic groups by occupational therapists and patients. Number 6. Integrating care. Reflecting the philosophy and values of occupational therapy, this principle recommends health professionals maintain a holistic view of patients and their recovery. Trauma-informed practice works to coordinate care within and between service providers and systems by liaising with other services and ensuring there is an overall plan for the patient. Number 7. Healing happens in relationships. Safe, authentic, and positive relationships greatly contribute to providing a safe environment. Research evidence indicates these relationships also enable recovery by restoring core neural pathways. And finally, number 8. Recovery is possible. Hope is incredibly powerful and extremely important for people experiencing trauma. Recovery is possible for everyone, no matter how traumatic their past. Reasonable or feasible hope can be enabled by all of the previous principles, and also by facilitating peer support, maintaining a strength and resilience focus, and establishing future-oriented goals. And finally, let's consider the role of occupational therapy in the context of conflict and war. In some ways, this session takes us back to where occupational therapy started in the early decades of the 20th century. Occupational therapy as a profession was formulated during World War I in response to the urgent needs of soldiers returning from the battlefield with physical and psychological injuries. Initially known as reconstruction aids, training was provided to health workers in the use of therapeutic activities to help wounded soldiers regain skills, cope with combat-related mental health problems, and return to productivity in their communities. Occupational therapy was subsequently formalised as a distinct profession with the establishment of the American Occupational Therapy Association in 1917. In my home country of Australia, World War II provided the impetus for occupational therapy to become recognised as a profession. However, by now there was recognition of our role with both civilians and combatants. I remember when I first met my husband's grandmother, and she showed me the beautiful tapestries and other textiles her husband made following the disabling injuries he got during the Blitz in England. For once in my life, I didn't have to explain what an occupational therapist was. She knew all about what we offered, from the meaningful activities that one of our occupational therapy ancestors had introduced him to during his recovery. And it was clear that it meant a lot to him and her. Occupational therapists have continued to work with people exposed to conflict and warfare into the modern era. While I'm sure we all look forward to a time when we no longer have to work in this space, occupational therapists have been doing this for over 100 years, and we have a lot of experience and evidence to draw upon. But if you don't screen your patients for trauma, you may not recognise its influence on their health, well-being and occupational engagement. Services may have existing processes and procedures for screening, but the assessments on this slide provide additional options for identifying these issues for your patients. All of these assessments are available online, and you will need to understand their various aims and purposes before applying them to your practice. They all have established validity and reliability, and therefore you can be confident they will identify trauma for your patients in a rigorous way. But what do you do as an occupational therapist once you've identified trauma as an issue for your patient? Aside from implementing trauma-informed practices across your service, let's reflect on the impact of conflict and war on the doing, being, becoming and belonging of occupational beings, i.e. people. From a professional perspective, war and conflict affect all aspects of occupation. People do many things as part of daily life, both alone and with others. These may include what you want to do, you have to do, and you need to do. The structure of doing is ruptured during conflict and war, meaning that people have less access to the health and well-being benefits of occupation. The effects of doing include fewer opportunities for activities, routines and habits being disrupted, little or no access to resources, and enforced changes in doing because of the circumstances that people find themselves in. All of which leads to less purpose and structure in daily living. And as occupational therapists, we know this is hugely detrimental to people's health and well-being. Being is who you are, including what you enjoy or find meaningful. Being includes your unique physical, mental, and social skills, your life roles, and the choices you make about activities. War and conflict shake people to their core, and many describe themselves as fundamentally changed by these experiences. The effects on being include exposure to dehumanisation, abrupt role changes or losses, damage to physical, mental and social skills, less agency and autonomy in daily life, and few opportunities for creativity and reflection, all of which lead to a loss of identity and self-determination. People change and develop over time. Everyone has hopes or goals to work towards, but change beyond one's control can happen. The chance to develop new skills is important as people adjust to change. War and conflict fundamentally change the future, regardless of who ultimately wins or loses. The effects on becoming include interrupted or restricted development, forced changes to goals and aspirations which may be long and dearly held, less exposure to novelty or challenge, which are crucial to offering opportunities to become and develop, a stagnant view of the person's future self, all of which leads to an uncertain future and limited growth. And finally, belonging is your sense of connection with other people, places, cultures, communities, and times. All people have multiple relationships with these things, and belonging happens when you experience sharing and mutual benefit. War and conflict tear families, friends, and communities apart. Effects on becoming include barriers to connecting with others, alienation and marginalisation, strained relationships, and a changed context for occupations, all of which leads to a loss of the comfort, reciprocity, and mutuality that belonging brings to all of us. In conclusion, trauma resulting from war and conflict embeds itself in all aspects of a person's doing, being, becoming, and belonging. It interrupts regular engagement in meaningful occupations, diminishes personal skills, and impedes occupational engagement. This form of trauma erodes our core sense of self, disrupts our life roles, takes away our agency and autonomy, damages a person's physical, mental, and social capacities, and affects the way we express our consciousness and creativity. Trauma resulting from war and conflict is a significant barrier to personal growth and development, forcing unplanned and unwanted changes in our life stories that may stop us from pursuing our goals and aspirations. It fractures our sense of connectedness with others and our environment, disrupting established relationships and impacting on experiences of culture and history that are crucial for social identity and support. So what can we do about all of this? Occupational therapists already deliver a wide range of interventions designed for other conditions, which are also applicable to trauma-informed practice. The list on this slide highlights evidence-based interventions which are supported by occupational therapy research. This provides a range of options for your practice, regardless of the age of your patients or their life circumstances. After screening, we must complete a comprehensive occupational assessment, which can be completed via a diverse range of approaches. Remember, the relationship between occupation, health, and well-being is our unique contribution to this area and to broader healthcare. Creative therapies have been shown to be effective in helping patients process and make sense of their trauma. They also provide opportunities for patients to use their existing creativity. As part of your assessment, explore how the patient likes to express their creativity. What are the meaningful activities and occupations that could enable them to have this creative expression? Culturally specific approaches to trauma have been developed which take cultural understandings and practices into account, along with historical and racial contributors to trauma. Your assessment should therefore also touch upon culture and the impact that this has on the person's occupational engagement. Environmental modifications may be very supportive for patients experiencing cognitive, sensory, or neurobiological symptoms of trauma. Given the occupational disruption and rupture discussed previously, occupational therapists can play a key role in reconnecting patients with meaningful occupation and re-establishing predictable routines. Children who have experienced trauma may benefit from age-appropriate interventions like DIR floor time, skill-building play, or considered toy selection. Knowledge is power, and providing patients with education about the effects of trauma can empower them to make sense of their experiences. Psychosocial approaches are effective for the mental health and psychosocial symptoms of trauma, and your assessment will indicate which of the many different options available will suit the needs and preferences of your patient. Another way to empower patients with trauma is to support them to develop their own risk management strategies. These can be tailored to the person's individual experience of trauma and their particular symptom profile. Sensory approaches have also been shown to be effective for addressing the sensory sensitivities that many people who've experienced war and conflict experience. These approaches are also effective in supporting better emotional self-regulation. There is also other skills training that can also support patients to take better control of their lives and self-manage their symptoms. In conclusion, we have the complex skills and expertise needed to address trauma for our patients. We can tailor support using our holistic understanding of the person and the many occupations they engage in. All of this makes occupational therapy very well placed to enable recovery for people experiencing trauma, whether this has been caused by conflict and war or another life experience. Here are a couple of options for continuing your learning about the role of occupational therapy in trauma. You may like to review the principles of trauma-informed practice and think about what you might already be doing that supports these practices. Now that you know about the principles, you could identify actions that you could take to improve your trauma-informed practice wherever you may be working. You could also explore how your colleagues work with people experiencing trauma. We often have a network of health and welfare supports from a range of different providers and carers that we can tap into. Learning from others is a great way to develop your practice. You also need to consider how your approach to trauma will complement these other supports so that the patient is getting some consistent care that doesn't have mixed messages attached to it. The 3 references on this slide will provide you with further learning and reflection about the role of occupational therapy in trauma. The first 2 are specifically related to trauma, while the third features compelling narratives from occupational therapists from around the world, including those in communities affected by conflict and war. Thank you so very much for listening. I hope you found this webinar helpful in your work with people experiencing trauma. And thank you for your work in your communities. Remember to look after yourself so that you can continue to enable health, well-being, and occupation for all. Please see below for a list of references that have been cited or utilised during this webinar. Thank you.